Some others may join us in a second or so, but I think we'll get started. Lots to cover off today. Good afternoon, everybody, and welcome to this symposium on the proposed introduction of video group clinics, or VGCs as we call them, to primary care. Just to let you know that today's session is being recorded, so colleagues who can't make it today will have ability to look back at that. My name's Jason Westwood. I'm a Senior Project Manager for this area of work within the Nursing Directorate and NHS England and Improvement. The project team and I would like to take this opportunity in the session to illustrate how the risks that we've been facing can be mitigated, how a combination of the technology that we're looking at can ensure that the elements like consent and confidentiality can more adequately be addressed, and introduce the scope of the group clinics project and more importantly about the demand that we are seeing around this particular area. Thanks in advance for your time and grateful for representation today from colleagues from the CQC, the RCN, RCGP, our colleagues at the NHSX, Tavistock and Portman NHS Foundation Trust, some of our medical defence organisations, and most importantly, some of our practices planning to be our sentinels for video group clinics. As a background, I just wanted to let you know that we have been introducing group consultations as an additional delivery method for primary care over the last 2 years, and it now stands as an outcome and a firm one within the NHS long-term plan. Times have considerably changed, I know, during this time of the COVID outbreak, and an accelerated move to delivering group clinics virtually has thought to benefit now, more importantly in the recovery phase, and be added to one of the elements that would support patients with long-term conditions well into the future. So during this session, we'll be using some of the principles of video group clinics, and we will be using these to illustrate how they can be applied. One of the fundamental parts of the delivery is the establishment of a facilitator. They're there to set up, control and to close a video group clinic and allow the clinician, more importantly, to concentrate on the session's topic. Can I now at this point pass on to our facilitator today, Helen Longstaff from ELC Works, the organisation who's been helping us shape video group clinics and undertaking the training for those who are wanting to deliver video group clinics. So over to you, Helen. Thank you.
Okay, thanks, Jason. Good afternoon, everybody. So I'm going to set our session up today together in the same way that we would set up a video group clinic with patients. So we're going to work today with our session flow. So this is our flow of what we're going to go through today. So we're at the minute doing our welcome and session setup. We're going to hear from a couple of clinicians and a patient about their experiences with video group clinics. Georgina's going to take us through the National Learning Programme design, and then we've got some information about the evaluation work that's being done. Then we'll look at the virtual platforms and the capabilities around that. We're going to look at risk mitigation, and then there'll be some time for some discussion and for answering of your questions, and then we'll take some feedback from you, and we will finish at 1:30. So this is how a video group clinic is set up for working with patients. And then this is how we're going to work together. And again, this is how we would work in a video group clinic with a group of patients. So these are the understandings that we use in a video group clinic. So we would like to ask that you're with us today, that we're all busy, but that we're in this virtual room together, and that we can stay curious. So you've probably got lots of questions, and hopefully we can answer a lot of those as we go through the session today. Let's listen to each other and respect each other's different views. Respecting confidentiality, so that's covered in much greater detail with patients, and Georgina will go over that in a little while. But for today, perhaps if we could agree that this is a safe space for us to work together to get through the session today and get you the answers that you're looking for. If we could ask you to stay muted on your microphones, it really helps with feedback, and use the chat please on the right hand side to communicate with us unless we specifically ask you to unmute. Spelling mistakes welcome, so don't worry about what you're typing in that chat column, and we really stress that with patients as well. And if your technology isn't working, I think we've done a check as most of you have come on, and we seem to be good today. But if your technology isn't working, if you can't see or hear us, send us a chat message and leave the session, and we'll get back to you afterwards. We will keep to time, and that's for all of us. So there may be times if we get a bit sidetracked on one particular topic that we might pull it back in the interest of time. And then I'm going to ask you if there's anything else that you need to add to that, so that we can work well together today. And if there's anything you can think of, if you could pop it into the chat column, that would be great. I can see that Jennifer has said that she's confused. Jennifer, if you have a mic, do you want to unmute and tell me? Hopefully I can clarify things for you.
I'm just a bit, can you hear me?
Yes, I can.
Sorry, I'm just a bit confused. I thought this was going to be the meeting to talk about, you know, what the next steps were regarding the holding of doing virtual group consultations, so that we would be clear on how we can move forward. If this is just another training session, I don't need to be part of it. So it all came through rather rapidly and I wasn't entirely clear. I thought this was about next steps and how we can move on, having been told to hold on running virtual groups.
Okay, it's not specifically about that. Georgina, do you want to add? Do you want to answer Jennifer's question?
So this is we're running a national session here. There are a few people who have attended who we weren't expecting to be here. So as I'm explaining what today is about, if you think that you might be in the wrong meeting, then do let us know. But Jenny, I think the impression that Jason had was that you were here representing the RCGP.
Oh, okay.
Yeah.
Because I can't stay for the whole meeting anyway, because we're frantic today. So I think in reality I'll wait for some feedback, because I've done one of these before. So
this isn't a training session. This is about how we're going to move forward with the group consultation, the video group consultations program at a national level. So it's a sort of national meeting of leaders of who can help support that and look at what the issues are. It's not going to be a repeat of things that you've heard before. Okay.
Dip in. So I will try and dip in and out, but we are really busy today, so I can only dip in and out a bit.
Okay, all right then. Well, you do as you need to do. Just drop pop something in the chat to let us know when if you are going to leave us. Yeah, is that all right? Fabulous, thank you. Okay,
thanks Georgina, thank you. Okay, so nothing else has appeared in the chat column, so I am assuming then that you're happy to work with those understandings. And then the next post that you'll see there is our car park. So we work with a car park so that we can take away any questions that we can't answer for you today. So as we go through the session, if you have any questions that come to your mind, if you could write them into the chat column, and if it's particularly relevant at that time, we'll pick it up. But please don't think we've ignored it. If it doesn't get answered straight away, we will pick it up. So I'm playing that role of facilitator today, and I will be keeping a note of all of the questions that come up, and we will pick them up at the end. So if you've got a question, just pop it into the chat column. You don't need to preface it with car park. We will post anything into the car park that we can't answer for you today, and we will take it away and get an answer for you and get back to you. Equally, if we go off track a little bit, we might put something onto the car park to pick up with you again at a later date, so that we can get through the session for today. So I hope that that's all clear. That is how we would set up a video group clinic. So I'm going to welcome and introduce you now to Dr. Rupa Joshi, who is going to talk to you about her experiences as a clinician working with video group clinics. So Rupa, over to you.
Thanks, Helen, and hello, everyone. So my name's Rupa, and I've been a GP for about 18 years, and I work in Berkshire, in Wokingham. And as you can see, I'm also a co-clinical director. I work for the Time for Care team as a faculty GP, and I'm just recently become the Southeast Region Rep for NHS Confederation. And I'm fortunate that one of our patients is also joining us today to talk about her experiences, Helen Dyson. So thank you as well for joining us today. So I wanted to talk to you a little bit about our experiences up till now. So we started doing face-to-face group consultations about 18 months ago. And I was really inspired watching a training session run by Georgina about a patient that had diabetes and she was attending a QOF review. And I was really moved by how she felt within the network, how it had supported her. And she was very tearful that, it had made such an impact on her. And that was the time when I thought, well, this would really benefit our patients at the surgery. And I really want to know more. So since that time, with our face-to-face consultations, we've done diabetes, pediatric asthma, pre-diabetes, chronic pain, fibromyalgia. So we've really enjoyed bonding as a team, working together, learning from each other's skill sets and different approaches. And there's been high fives down the corridor and, great team spirit. And the patients as well, their feedback. We've had reduction in A&E admissions, reduction in GP attendances. So it's all been documented how well that's been going. And then with the COVID lockdown, we thought we'd seen the benefits. And we really thought that we've got to go virtual. Our patients need the care and they also need the support during the time of isolation. And we've seen go with an echo. Okay. I don't know if anyone's not muted. I'll keep going. Yes, that's better. Thank you. I've still got an echo, but I will carry on. We really thought that it's something that we wanted to pursue in a virtual setting. So our team consists of our new ARRS that we've employed. So we've specifically employed a health coach to help us with our group consultations and virtual group consultations. And she literally started this month. We've been using the skill set of our social prescribing link worker. And we've got myself, a practice nurse, a healthcare assistant, and using our admin team for the facilitation has really helped for their job satisfaction, well-being, and knowing that what they're doing is part of healthcare and seeing their good work transformed into helping patients. So we started doing our first virtual group consultation was on asthma. So we looked at our shielded patients. We invited all our shielded patients with asthma, invited any patients that had quite a few courses of steroids, recently invited anyone who'd been in hospital for asthma, and invited patients who had 3 courses, 3 different treatments, including inhalers and montelukast and so on. And that was our first virtual group consultation. We had an excellent session, really good feedback. We managed to do care plans, and we managed to look through who had peak flow meters, who techniques of inhalers. We had questions posted, the difference between COVID symptoms and asthma. Now you have asthma, what do you do next? How do you protect yourself? And our health coach really talked about keeping well with diet, lifestyle, breathing techniques, well-being, and our social prescriber told us about what was available in the community, such as the delivery and the shopping services. And we had a really, really satisfying session through that. The following week, we've been doing them weekly. It was really, it was a whole team approach of which patient cohorts we wanted to look at. And our team was saying, well, there's a lot of patients calling in with anxiety at the moment due to being in lockdown, losing their normal support networks. So we put on an health, anxiety and wellbeing, using the same kind of concepts of the MDT team. And we said to patients, if you are a bit anxious, you don't have to come on video. You don't even have to come off audio. You can write in the chat box, do whatever, you feel suits you best. And since that one, actually, we've had more feedback from the team saying, please, can you do another one? Because we're getting more and more patients as the lockdown's easing. We're getting more and more patients that are requesting to come. The next one that we did was in response to the fact that unfortunately we've had an increase in safeguarding cases, non-accidental injury in our region. At that time, we were reported to have 4 patients who had attended A&E with shaken babies, which was really, really sad. And then since then, it's now been 7. And the safeguarding team and the health visitors are putting a campaign together. And I just thought, well, I can't sit back and let this happen when I know I can reach some of these patients. And then we found out that there'd been 1 death and 1 baby in ITU, all under the age of 12 weeks. And the majority were no mental health issues in the past, fit and well parents. We were particularly concerned about dads. And we put together a virtual group consultation and invited all postnatal mums with babies under the age of 12 weeks across our primary care network. So 5 practices all got together, did the searches, invited patients, and we had an excellent session with 26 families that we could reach, and we invited them to speak about how they were getting on. We had our health visitor colleague come in, and she framed a beautiful video on a crying baby, where the crying just escalates and escalates over the course of the video, and the dad saying, "I've checked the nappy, I've checked the feeding, I don't know what to do," and his voice gets more and more faltered as the time goes on. And it was a really powerful video, and it was just to raise awareness that you can walk away, you can recuperate yourself, and you don't have to keep kind of circling and getting more and more anxious. And I think at that time we talked about what was going on in the region, and we reacted, and we also did the same the following week, where we had more and more children with anxiety, children with behavioural problems. I had one child who was biting parents and was holding a knife to his neck. Is only 6 years old, and I thought we've got to do something for these children. So we put forward a children's health and wellbeing group, with a specialist GP who's trained in children's mental health. And all of these sessions, we've also had our talking therapies, mental health therapist available. So it's been really multidisciplinary. It's been a great way of delivering care. And of course, we've now been asked if we can do these postnatal groups every 3 months to catch the next 0 to 3 months. That's ongoing post-COVID, post-recovery. And we've also now been asked to do the 3 to 6 month group to talk about dangers in the home, open windows, water problems that we've also seen in the past, and also talking about getting ready for weaning, household accidents, all that kind of thing. So it's been received really, really well, and I've had lots and lots of feedback from people saying that they'd be interested in setting something like that up for their patients. And we're putting on a webinar next Thursday on what we've been doing in the community, looking at how patients can really empower themselves to self-care with our health coach, going through the nutrition side of things, informing patients of what's happening locally with our charities and voluntary organisations, because our social prescribing link worker is recruited from a charity, which we thought would be a better way of utilising that skill set. So we're really excited about what's in store next. Sorry, next slide, please. So this is what we're looking for, another anxiety group, the 3 to 6 month, and we've very open to the team. We're having kind of QI sessions with the team to go through things like ideas generation, shared purpose, trying to find out what the best way forward is and how to help our patients. So we're looking at diabetes, healthy living, reinstating our normal workload, looking at our normal diabetic follow-ups, because we don't want to leave them too late, particularly those that really need us with high HbA1cs, as we know they're more likely to have poorer outcomes if they catch COVID. And just any other areas that our patients feel would benefit. Our team is raring to go. We're inspired. We've had excellent feedback. We've worked really hard on the consent and confidentiality issues to try and make sure that we've mitigated all our risks, which I can answer questions for you later. And I'll hand back to Helen, and please feel free to ask any questions.
Thank you, Rupa. So if you have got questions for Rupa, please do pop them into the chat column. And we're going to hear now from a patient, Helene Rainsford, who's going to tell us about her experience as a patient of video group clinics. Helene, thank you.
Hello, thank you very much for inviting me today to give a view of how us patients have found the clinics. My experience was that I received a text message that said they were running a clinic where you could ask any questions you wanted with regards to COVID. At the time, I didn't really think it applied to me because I didn't really have any questions. I was just going with the logic of stay at home and don't catch it. And when I then had an email, it told me a little bit more about what the session would involve. And I thought, actually, this might be very useful. And it was made clear from the beginning that it was going to be a very safe space to ask any questions you wanted to ask things specifically in relation to asthma and COVID, and some other areas that Dr. Joshi's mentioned with regards to social prescribing and things. There was really good contact beforehand. I went into it kind of feeling really briefed in what was going to happen and what was expected. For me, although at the time I wasn't particularly anxious about COVID, I've previously worked in public health, so I know where to get the right information from, where to get trusted information from. But I think that for the general patient population, it can be quite a worrying time when there's something going on in our current situation, and knowing where to get your safe and trusted information. And your GP surgery really is a really trusted place that that you would go to. So for me, it felt that it was brilliant. We had this information specifically about COVID, specifically about how it could affect our long-term condition, and then when to take action and go down either an asthma route or a COVID route. And it just felt that it was information you could trust. You could just forget everything else that was going on in the press and the media or on social media. And just utilise that information. There felt like there was a real range of other patients on the call, from some who say were older to younger, some whom might have been less able or less sure where to get reliable information. So it felt like it was a really timely thing to fit in. At the end, there was lots of time to ask questions, which is great, and it felt like I asked a couple, and I felt that the group asked quite a wide range of questions. The benefits for me about having a virtual clinic, it fits into my day so much easier. So when I was working full time in a really busy job, going to the doctor meant that you'd have to take time out of your day, you had to put time in your diary, and having a long-term condition, I was always very, very conscious that I didn't want to be the employee who was always going off to medical appointments. So if I had to go for a medical appointment, I'd always make up the time later on. Now, actually, if we could do it as a virtual clinic, it would mean I could just book a meeting room for an hour or half an hour and go in there and shut the door and do it at work. It only takes an hour out of my day, and it reduces the amount of time. Also, now, when I haven't been so well in the last couple of years, actually going to the GP surgery when you're not feeling great, and say times when you've just come out of hospital after surgery, actually physically getting yourself to the GP surgery can be quite tricky. And there's been times after spinal surgery where I couldn't drive for, say, 6 months, and I'd be reliant on someone else. And it just takes away all of that. Really sorry, my iWatch is talking to me. It takes away all of that element, and really don't underestimate the stress of parking when you're going to a GP appointment or any type of hospital appointment. And especially if you're a wheelchair user like myself, trying to get access to the accessible parking can be the most stressful part. So having something where you are not reliant on anybody else, there's no barriers, you can just crack on and get involved wherever you are. A great element was feeling connected with others. I know when I went from working in a very busy role to then suddenly being in the spinal unit, and then coming home, I felt really disconnected, and actually having something that was about self-management of a long-term condition, regardless of what conditions the other people had, I think would have been really beneficial to me, because it would be something I could have done at home, because at that time I couldn't have gone out on my own anywhere independently, and it would have meant that I could have kind of stayed connected with other people. I think camaraderie is a huge tool when you're trying to look at positive self-management of long-term conditions. I'm not really a fan of online support groups, because I think they can get a little bit scary and dark, whereas I think if you've got something that's being managed by somebody who's linked in with primary care, it's obviously, I feel it would be a much more positive and directed experience. When I did work in public health, we ran a programme which I think was called the Expert Patient Programme many years ago, and we did a session that was a whole mixture of conditions, and I had one individual who the GP surgery had said, "You'll never get him to come along, he's really negative, really tricky," and they came along, and the session, we had a lady there who had MND, and her patient view changed the whole dynamic of the group, and it really changed the other individuals on there and their whole positivity and mentality towards the long-term condition. And that group then kind of at the end of the session moved away and took ownership of their kind of get together, and started doing things as a social connectedness away from that. And I think you've probably got opportunities with clinics for long-term condition where that could happen. I think there are just elements that you could move this just away from specific conditions through to things such as the kind of social prescribing element, or even things such as exercise referral. I'm a real firm believer in the kind of benefit of physical activity and within medicine, yet actually going to a protein pumping lycra-clad gym when you're, say, just recovering from surgery isn't kind of a great environment. But actually, if you could do something that was exercise at home directed by someone within primary care, that would be kind of really beneficial. So for me, I felt the experience was great. I felt safe. I felt free to talk about what I wanted to talk about, and it certainly would be really beneficial for me going forward.
Thank you, Helene. It's really inspiring to hear about your experience. Thank you. And so finally, I would like to introduce you to Dr. Sarah Morgan from Hampstead Health Practice, who's also going to share some of her experiences with you. Thanks, Sarah.
Hi there, it's actually Hampstead Group Practice, I didn't notice that. I'm just coming at this from a slightly different angle, in that I'm one of the long-term condition leads for North Central London, and obviously we're all discussing the recovery phase now, particularly around long-term conditions. And we've in our practice been doing face-to-face group consultations for the last 2 weeks, particularly with our diabetic patients and patients with COPD. And they've been hugely successful with, much better outcomes often than when they come to see us on a one-to-one traditional model face-to-face consultation. So we're very enthusiastic and definitely see virtual group-based consultations as a new way of working that may help us, given that at the moment we are looking to remotely work with patients as much as possible, keeping face-to-face contact only in essential cases. We're also keen to build on the self-management that's obviously come about in recent times. And so in NCL, we're looking at a project where our diabetics, patients with coronary heart disease and also with chronic kidney disease and uncontrolled blood pressure, where we start to run these virtual groups across NCL and provide home blood pressure monitoring machines if patients don't have them themselves, link in with social prescribers and really sort of address the whole sort of personalisation and self-management, but use the vehicle of virtual groups as a way of delivering that. I know a lot of colleagues are concerned at the moment because although we're doing a lot of things on telephone and video, often it takes longer to do it. And we're worried about demand and capacity as we have to find new ways of working moving forwards, and how we're going to manage to continue to work with that COVID risk and infection control, but also manage the business as usual. And I think, again, there's a real appetite that by maybe spending 40 to 60 minutes, with 6 to 8 patients, giving them much more time with us, but also in terms of times efficiency and as a way of the recovery phase, this being a way of working, I think we feel it's going to be a really important integral tool. So I just really wanted to let people know that definitely I think other areas I'm sure are thinking about it similarly, and certainly at our practice we're desperate to use it in all sorts of other ways, but across NCL we've already written up our project plan and are very keen that all patients are offered to participate in this. Happy to take questions later, but I'll leave it there for now.
Thank you, Sarah. So, as we said, if you've got any questions, please post them into the chat column. And now I'm going to introduce you to Georgina Craig, who's the National Programme Lead for Video Group Clinics from the Experience-Led Care Programme. Georgina.
Hi everybody. So what I'm going to do very briefly for you is to just share with you the overview of the programme, what we were already doing before COVID, how things changed when COVID hit, and the sort of rationale behind the design of this national programme. I'm the delivery lead, so Jason is very much the lead at NHS England and improvement, but I'm working together with Mark Schmidt from Redmore as the sort of delivery partners to make this happen. Work supporting practices at grassroots level. So the first thing to notice is that we actually were already planning to do a program around video group clinics in 2020-21 before COVID hit. We started talking about this on the 22nd of January, and by sort of February we already had a plan. That plan was a much lower scale plan of what we were going to deliver compared to what we are delivering now. We were planning to do quite a lot of research to start off with, to really unpick the benefits of the face-to-face model from a patient and clinician point of view, also of the video consultation model from a patient and clinician point of view, and then bring that all together and co-design a video group clinic model with patients and clinicians, and then work with the providers of platforms to help them to look at how they could respond to that model. Obviously, COVID hitting meant that there was clearly a sort of really strong rationale for actually making this program very different and doing more of an action learning approach based through a continuous improvement cycle, where we actually work with a group of pioneer practices who we've called sentinel practices, and actually learn as we went along, so that we could potentially scale this up much quicker. So I'm just giving you this so that you can get an idea of timelines. So we started to talk about this on the 12th of March, and by the 6th of April we had started training and briefing sessions for our sentinel practices. So it was a very quick, accelerated approach that we've taken. Next slide, please. So also, just to give you a bit more context about how we have been developing this program, we had a number of design principles that have underpinned the program right from the start. So those were to build on existing programs and plans. So Redmore Health were already doing a lot of work around how to introduce digital solutions in primary care. ELC were obviously doing a lot of work around delivering, supporting teams to run group clinics in the real world. So we wanted to use all of that knowledge and insight to help us to build this program. We also wanted to minimise the need for primary care teams to invest in technology, and we thought this was really important because we don't want to predicate every digital development with the need for big investment across the whole system. So whether that was platforms that were already on the NHS framework that allowed for groups, or as we've quickly recognised, MS Teams, which had been made available to all primary care practices, and as COVID kind of embedded, that was actually accelerated again. So we were building on the assets in the system that were already available to us. We also continued to stay committed to working with clinicians and patients to co-design video group clinics. So our original aim was to actually recruit 42 sentinels. We ended up achieving on that one and getting 70 sentinel practices signed up to work with us. We have a spread of sentinels. There's probably about 4 or 5 STPs across the country where we have no sentinels, but apart from that, we've got at least 1 sentinel in every STP. And that's really important, because when it comes to spread, those local sentinel practices are going to be critical to sharing the story and helping others in their areas to understand that this is a really feasible way of working. These sentinel practices will be sharing their experiences with us, and already have been, and some of the risks that we've identified are things that sentinels have alerted us to. And so it's a very organic and improvement based approach that we're using, where what matters to practices and patients is right at the center of the program. We're also making sure that the way that we deliver group clinics really supports community connection and and improves the well-being of the participants. We, as we get further into this COVID journey, the impact on people's mental health and resilience is becoming really clear, I think. And as we move into a recovery sort of mindset, the more that we can do to bring together people with similar lived experiences, the better it's going to be for the well-being of everybody. And so that is central to the delivery of this model of care. We also want to make this really simple for primary care. So every opportunity we have, we're challenging ourselves on how to simplify the systems to deliver this, and providing templates, planners. You'll hear about evaluation in a moment. It's all critical, and it's all we're making it as simple as we can. We also want to make sure that teams have good tools to manage group dynamics effectively, and we've been building and continuing to build a sort of set of best practice around that, which is part of the training. And also, it's always been our priority, and it's always been our focus to think beyond COVID. So this was not a programme that was set up in response to COVID. COVID has accelerated this programme. And what we are hoping is that through this programme, we will have built a really robust additional tool in the primary care care delivery toolkit that will help people to remain, general practice to remain resilient, as well as its patients moving forward. We are currently in our phase 1 Sentinel phase, and we have paused the Sentinel program just now so that we can make sure that we've got good, robust solutions to the risks that need to be managed. And then we hope that phase 2 will start certainly in the summer through to autumn. And that will be when we build on the Sentinel's experience and start to roll out and make the training available, and the toolkit to any practice in the country that is interested in getting involved. Very, very quickly, just so that you're clear on how the process works, there are 3 roles in a video group clinic. The first one is the clinician, who is the one who is consulting with the patients. Then we have a technical facilitator, and then who is playing the role that Helen is playing today, and who manages the group and makes sure that everybody is engaged and has a voice. And then there's obviously admin jobs that need to be done, and they're done by somebody who takes that role, which is a clinical, we call them the clinic coordinator. The amount of work from a coordination point of view for a video group clinic or a group clinic is no more than usual for organising any clinic. It's just different, and once practices have embedded this as a part of their standard way of working, the admin burden is very similar to any other model of care. Next slide, please. You've already seen the session flow that Helen set up for today. So this just sets out the session flow for a video group clinic. There's a couple of things to notice about it. The first one is that the clinician is only present for about half of the time. So the clinician, everything is set up for the clinician, all the tech, making sure that the patient's tech is all working. The facilitator also consents the patients using a 3-step process, which Jason will share with you, and also shares some stimulating information with the group to help them to think about what they might want to discuss with the clinician. And we'll share you an example of this in diabetes and point out a couple of things about this, what we call the results board. Once the clinician leaves, the facilitator works with the group and helps them to reflect on what they've heard and to set some goals about what they're going to do to keep themselves well. So next slide, please. So this is an example of a results board. Notice that it's everybody's first name on that results board, and we usually recommend 5 to 6 different metrics to be on there, and it's really important that where there is a normal range, so this is a diabetes results board. Obviously it's quite easy in diabetes because there's quite a few metrics that relate to measurable things. It could be, however, other things like sleep, mood. If it was a pain clinic, it might be also something around managing pain, pain scores and that kind of thing. So there's lots of room for flexibility here around what you choose to put on the results board. What we know about the results board is that it's like the magic ingredient of the video group clinic, and when people see themselves in the context of a group and they see how their measures compare to other people in the group, it has a profound impact on how they relate to their condition. And it means that they actually sometimes for the very first time really deeply understand that they are living with a condition, particularly if it's an invisible condition like diabetes, and that they need to take control of their health and their lifestyle. So it's a very powerful tool, and it's really important that we preserve confidentiality and that we keep the results board as an integral part of the group consultation model. Next slide, please. I think that might be me now. Fantastic. So that's me. Again, just pop any questions in the chat. We will be coming to them during the Q&A. Okay, thank you.
Okay, thanks, Georgina. So we are working with the University of Oxford on evaluation work for this programme, and Dr. Crisanti Papuzzi is leading on that for us. Unfortunately, she wasn't able to join us today, but she has sent us a recording that she wanted to share with you. So we're going to show you that now. It's what she would have said to you had she been here. So Anna, if you could play the video, please, that would be great.
Thank you, Helen. I'm just going to ask if everybody could actually switch off their microphones and switch off their cameras. Because we're playing a video through this, I just don't want it to lag for you. So if you could just switch them off, it might make it a little bit better for you to be able to hear and see. If it does keep lagging and you're not able to see, we are going to send you a link to this video so you can watch it afterwards.
Hi, my name is Crisanti Papuzzi. I'm a senior researcher at the Department of Primary Care Health Sciences at the University of Oxford, working in the IRIS unit, which is led by Professor Trista Greenhalgh. I'm really sorry we're unable to make it in person today because of prior commitments, although I will try to cut the last half an hour, 15 minutes if I manage. Even in this way, I just wanted to contribute from an evaluation perspective, as we have just recently started looking at video group clinics in primary care. This fits into a wider program of work the team has been doing over the last 10 years now with some of the major grants here. We have published a number of academic papers and also guidance documents for clinicians and for patients on setting up and conducting remote video consultations. I can send the references if anyone is interested. This includes work in the COVID-19 context. We're also just about to submit the final report from a recent NIHR-funded study on face-to-face outpatient group clinics for young people with diabetes and the other complex health and social care needs. We know from trials that group-based care is associated with improvements in clinical biomarkers, problem-solving ability, quality of life, and reduced time commitment for clinicians compared to standard one-to-one appointments. In this study, we explored feasibility and scalability of outpatient group clinics for young adults who are usually less engaged in their diabetes care. I'm not going to go through it in detail. You can see some of the publications here. I just want to point you to some of our findings on staff and patient experiences. So as with any new model of care, implementation required effort. Training was important, and I was glad to see how comprehensively this is covered in the current video group clinics model. Selection of patients for group clinics was also not a random process, but carefully thought through based on in-depth knowledge of patient needs, how the patient would cope in a group setting, etc. In our Together study, there were also a lot of discussions around how much patients should be sharing about their clinical condition in the context of the group, whether it would be appropriate to discuss individual glucose monitoring, for example, in this case. We found that patients thought it was really helpful to be able to talk to others with diabetes. As you can see from the first quote here, some had never met anyone with a condition before. Some patients said group clinics helped them engage with their condition when previously they felt shut off. Group discussions also opened up potential for clinicians to start having different conversations with their patients. So things that patients would admit in group clinics, they wouldn't have necessarily discussed previously in individual consultations. Patients also felt they benefited from listening to others discussing their practical experience managing the condition, rather than what they saw as the clinical perspective they got from their clinicians. Quite interestingly, with our young patients, some thought remote participation would be a given, which we were able to facilitate in one case. Now, in our work on video group clinics, we are bringing together expertise in video consultations and in group consultations. Our work is based on the NAS framework, which takes a socio-technical approach in that we are looking at the technology as well as the social context in which the technology is implemented. The NAS framework covers a number of domains. I'm not going to go through them, but just want to say that it gives us a comprehensive evaluation framework to understand where complexity lies in technology projects and how to work with this unavoidable complexity in the implementation of new models of care to gain more value, rather than wish complexity away or ignore it until it has become a big problem. Currently, we are running a wider program of work on video consultations, which have seen a significant increase in recent months. Barriers that used to be in place no longer apply, and it has become much more straightforward for clinicians to use one-to-one video consultations, at least to provide good care. Within this program, we have started a focused evaluation on primary care practices running video group clinics. We are looking to collect critical data that will be useful for post-COVID sustainability as well, rather than just the current emergency context. We have carried out scoping and exploration in the context of the Sentinel program. We're also planning a patient survey to understand use of patients who have taken part in BGCs, and a small number of case studies, more in-depth work on staff and patient experiences, as well as talking to national policymakers, our focus being on what has gone well, what hasn't, what extra support is needed, how staff and patients feel they benefit from the VGCs, with the aim to support continuous improvement and learning as part of the Sentinel program. We're also hoping to get some more funding to do further evaluation, including quantitative analysis, clinical markers, and also co-production of the video platform, potentially to provide more options for patients, more choice around anonymity if they so wish. A brief look at initial findings. This is a very new model of care. We know little about how it works, for whom, where. We do need more data to be able to draw such conclusions. There are transferable lessons we can draw from other areas, and many of these are already incorporated in current delivery as far as I understand. We also need to understand how this works at scale rather than just one-off local implementations, because it's the learning across settings that provides most value. From our 12 initial interviews with clinicians so far, we're finding that most video group clinics are about long-term conditions, mild COVID symptoms, potentially also welfare checks as part of social prescribing, or to engage vulnerable groups who need extra support. Clinicians want to be able to reach patients who are shielding, to provide the social connection and overcome mobility barriers, which are not just COVID related. Some people are housebound and traveling is difficult regardless. Video provides extra cues that allow patients to build trust with each other and with clinicians. But at the same time, patients can control what others see. For example, they could turn off their camera if they want to. And as we have learned from our previous work, they can also control what they want to share, at what stage they feel they have built enough rapport with others to do so. Our interviewees also identified video group clinics as an opportunity to increase staff retention and support leadership potential, also the potential to work from home more flexibly or if self-isolating. My understanding is that many clinicians have already embedded VGCs into their service provision in different ways and will continue to provide this as they see value in being able to engage their patients in this way. I also know there is a lot of activity going on with VGCs in secondary care at the moment as well. There is a learning opportunity here. A lot of the discussions around VGCs currently resemble what the people used to talk about in relation to one-to-one video consultations a few years ago, where it has been possible to work through some of the challenges. And in a complex system, there is always going to be risk. Some of it can be predicted and contained with reasonable measures and considering balance to benefits and also clear management of patient expectations. Thank you for your attention. I'm happy to follow up by email if more information on our work would be useful.
Okay, so that's some information about the evaluation work that's being carried out for the programme. Now I'm going to introduce you to Anna Buckle from Redmore Health, who's going to talk about the online platforms.
Thank
Anna.
you. You've probably already heard my voice button in to tell everyone to switch their cameras off for playing that video, because I've been controlling the slides today. So I'm the programme manager for Redmore Health. So we've been supporting the Sentinel practices in using the different technologies available for running video group clinics. So there are 33 online consultation products available, but not all of these can actually run video group clinics. They can run one-to-one video consultations with patient to clinician, but not all of them can do group clinics. So it's actually that this project is ahead of the times, it's ahead of the technology, which is a first for me. But yeah, so there's only 7 at the moment that can actually run video group clinics, or they're on the roadmap to doing that. So they've got it in their roadmap to update the software so it is able to run a video group clinic. So currently the work that I'm and Redmore are doing are undertaking a capabilities audit on all the softwares. So we're looking at the 7 softwares available and looking at the capabilities these have to make sure that we can cover off all the different needs. So we've asked a set of questions to each of the platform providers to establish the different questions that we need to know before running a video group clinic on them. So we've asked them to answer questions on the core functionality, so the core functionalities of their product, the process of running a video group clinic on their product. So we need to know before, so how a practice was set up a video group clinic and get consent through their platforms during, so the different functionalities during that they need to know. So it might be sharing their screens or putting something into the chat bar, like we're doing today, so that the patients and the clinicians can have a conversation with each other on that, and then afterwards as well. So using Microsoft Teams, you are able to look back at the chat, and so it means that clinicians will be able to look back through the chat and see which questions have been car parked, so that they can look at those questions and get back to the patients and follow up with them. So we're just looking at the different processes that these platforms have got. And we've also asked them to answer the questions on data processing and governance processes as well. So that's what we are doing in the audit at the minute. So some of the platforms won't have all the capabilities that are needed, so it will be a necessity that practices might need to use different technologies at the same time as using one of the platforms to meet all the needs. So, for example, a practice might need to seek consent via secure messaging. So they could use AccuRx as a workaround for this. So yeah, we're currently doing the audit, looking at all the different products, looking at the capabilities, and then if there's something in it that doesn't meet all the needs, we're looking at a workaround for that. So the additional methods that they will use will have all the same governance checks to ensure compliance with the NHS IG requirements as well. So they'll all be up to scratch with the same. So that's everything from me. I realised that was really brief, but we are running a little bit behind, so I've just gone through that quite quickly. So I'm just handing back over to Jason.
Great, thanks a lot for that then. Great, thank you. So I'm just going to spend a little bit of time working through some of the risks that we've faced. With every clinical operation, we know that there are risks involved, and we first saw those being addressed when remote and online consultations were, if you like, introduced to the primary care system over a number of, if you like, years ago. Anna's just talked about there that we're a little bit ahead of the technology, and these is some of the reasons why the risks are, if you like, unique to video group clinics. So I'm just going to spend a little moment working through some of those, and we've grouped those, next slide, if that's all right, into 4 particular areas, and they centre around the clinical delivery of this as a principle, the identity and location of participants of the video group clinic, also gaining a real good informed consent from all participants that are being involved in the video group clinic, and more importantly, the confidentiality and privacy of all those taking place as well. Next one. So the first area really is around the clinical areas, and we know that to undertake this safely, a real good risk assessment has to be undertaken by all those who are undertaking or thinking of undertaking video group clinics. We are looking to establish a template data protection impact assessment, which is one of the primary things that needs to be covered at first before starting something along these lines. The risk management standards which have been established really need to be supported, and we want to work and help to support that in, again, providing templates that are part filled and start to really make people aware of that. And more importantly, we recognise that there are some risks that will remain there but need to be managed in a particular way. And in that particular ilk, we're looking to provide hazard and risk logs provision for that as well. A really important theme, and you saw that in our colleagues in Oxford highlighted as well, is the provision of adequate training. So we'll be undertaking Sentinel training when that restarts, and they're on a feedback cycle with ourselves to tell us where the issues are arising and really get us to have a good working knowledge of how video group clinics are being provided for. We then hope to move towards a national training programme, which will be open to all those practices, and the intention is really to make sure that all those who will take part in video group clinics are well aware of the issues, the risks, and be able to really adequately support and deliver video group clinics. In addition to that, we hope to leave that there always will be questions and provision within the national training afterwards. We'll be dropping clinics to talk about some of the technical areas. I know somebody in the chat box there mentioned about the tech, and also around there setting up a community of practice where we can really make sure that the good practice that's going on out there, and if there's any issues still arising, can be addressed in a community. We recognise that around this clinical area, indemnity is really important. And in this particular instance, because delivery is so diverse, some of the key areas are that talking to the medical defence organisations is actually a key outset from the beginning and should be done. We'll be encouraging that to happen from the outset. We'll also be encouraging extra extended liabilities that probably weren't thought about before. So data and cyber risk insurance that could cover off data breaches that primarily we recognise in this particular instance, the clinicians aren't necessarily the larger percentage of the risk, the patients are themselves. So I think that's something for us to have a look at. Next one, please. So the identity and location is one of the key things that we need to find out and make sure that who is taking part in the video group clinics is genuinely who they are. We'll be following the patient online services in primary care guidance, which is very comprehensive, and seeking the same type of approach. So that three-part process of making sure that people are who they say they are, but actually moving to more, obviously, taking into account our move to a virtual environment. So using the security words that we discuss with patients and a combination of technology, like Anna was saying there, to really confirm that identity. Some of the areas that we want to pick up around the patient's location needed really. So if during a clinic, if an urgent requirement is required to give that person urgent care, etc., then we have their details very securely. We can use a number of methods which are also make sure that they confirm both the location and they actually give us partial ability to make sure that that confirms their identity as well. So a combined approach there. Next one, please. So consent is really important, and our real key area around here is to make sure that we get to an area of informed consent. So in advance of a video group clinic, the recommendation is that we'll be sending information about personal privacy. So some of the platforms do have settings that can be reviewed to make sure that privacy is set more comprehensively. We're working with a number of parties and have drafted a confidentiality agreement that can be sent in advance. And more importantly, really then also make sure that people are aware of what the VG subject is about and how much information will be shared. So a little bit like we showed earlier on about what will be contained within the results board. This is done really on a controlled fashion, and the information that we're using and going to provide make sure that that's planned, and so therefore sharing of information really is in the controlled fashion. So we mentioned earlier on there about a three-part consent principle, and we use and advising to use a three-part. First one being implied, so a person accepting the invitation to a video group clinic is in short accepting an implied consent because they've read some of the information we've talked about there, the privacy advice, the confidentiality. We're then doing it again right at the beginning of a video group clinic every time to make sure people are really aware and they have the opportunity to leave if they wish, or swap their interaction to a one-to-one, which can be done later. And then finally, to make sure that it's belt and braces, a recorded approach can be used, again multi-method. This can be either with the system's own capability that we're looking at which ones can do this, or that multi-method by using a secondary tech system to make sure that admittance of consent to move forward is recorded in the medical records. Next one, please. So the final area really is around consent confidentiality and privacy. So confidentiality in this particular instance is really important, and is probably the most important part for the patients themselves. So again, as I said, we mentioned about bringing together a confidentiality agreement about the sharing principles, and we're working with a number of parties who have so far had difficult cases to deal with, and difficult groups, to make sure that trust is there. We'll be using planners to introduce the principle of controlling the information and making sure that it's stored safely and can be included on the medical records. And more importantly, on the privacy front, offering personal privacy information assistance about how to combine again their technologies, and make sure that they review the settings, and make sure that this reduces the risk of breach. So finally, just moving on to the last slide from my particular instance, and leading us into our questions and answers session, is some burning questions. We really do need to, if you like, broach these subjects, because it's a big trust element that we all are talking about in moving forward with this as a principle. So some of the key questions are, if, for example, a participant themselves chooses to digitally share some elements of a clinical situation, who exactly is responsible for that breach? If all the principles have been followed and everything could have been done by the clinician, again, who's responsible for that breach? Again, around the patients who share either visually themselves or verbally, etc., something intentionally, or they may do it by accident. Again, if all has been covered, again, who is responsible for this? I think where we stand now is a little bit of an area where we've not actually been before, and we've mentioned on a couple of occasions that we're ahead of the technology for a change. And I think finally we have to ask a really big question that we've probably not had to ask before, is, do we really trust the patients to be as confidential as we need them to be? On this particular instance, I'd love to bring in others to answer those questions, and particularly Helena, who may have a real insight, being a patient herself, on how that was handled in her particular session. Thank you.
Are you happy for me to give my point?
Brilliant. Yeah, thank you, Helena.
Yep. So I think for me, for the session itself, the confidentiality element was really integral to all parts of the communication. It was really evident in the email about how that was going to create a safe space for us. We had to consent to that again in the chat box. And even when somebody joined the meeting late, the facilitator stopped and asked them to agree to the consent in the chat box. So it almost was very much just part of the fabric of the session. And it was a really firm principle. I think that you should trust patients to a certain extent. We are trustworthy, we are adults. Those with long-term conditions probably have a greater understanding and respect for each other's confidentiality. And we know that if someone was to breach that confidentiality, this resource that we have will go. So I think patients will have that element of respect. I also think that I know that they're patients to all of you, but actually they're people away from the clinic, and they probably have experienced confidentiality in other settings. I'm a non-exec director on 2 organisations, so I clearly have to understand confidentiality in that sector of my life. So I'm going to understand it when it comes to a clinic. I think in the session itself, one of the individuals, they disclosed a very tricky social situation relevant to their home and the impact on that with COVID. And clearly, if that information, you could tell the person was quite concerned about it. And if that information had got out of that session and got back to the challenging, so other people involved in that challenging social situation, you could see that would be of detriment to them. So actually, they clearly felt very safe in disclosing that information. There was no pressure to say anything. You could have just kept your video off. You could have not said anything. And actually, there was a question I wanted to put over. I didn't put it over in the session, and it wasn't because of confidentiality. It was because there was a number of reasons why I could have been on the vulnerable list, and I wasn't too sure which one it was. And actually, I didn't really want to play, medical condition bingo in the group, so I just emailed it afterwards to Dr. Joshi and had that conversation separately. But that was not because I was concerned about confidentiality. I think the other element, that I've been in so many situations in hospitals where my entire medical history has been read out, where I've got just a curtain around me, between me and 6 other people and their relatives, and there's no element of confidentiality kind of protection there. And in fact, I've actually had someone else's medical history read to me at the end of the bed by an anaesthetist. And when I said, I don't think that's me, and the person next door said, I think you're talking about me. So I think, you kind of, there's other areas where there's quite significant risks with it. And I think in today's technology, even if you've got a group in a practice, you're not taking people's iPhones away or dictaphones or whatever. You never know whether someone's going to have that. So I think there's all sorts of elements. And for me as a patient, the benefits of access to this really do outweigh those risks. And I would feel confident. And as the group progresses, and if it's not just a one-off group, you'll build that rapport amongst one another and that camaraderie.
Thank you so much. That's really useful and helpful information. Thank you. Okay. So we have got a few questions in the chat column, which I'm going to pick up with different people depending on the question. So the first one, Georgina, can I call you in, please? There's 2 that are linked really, so I'm going to give you them both. So Maggie asked, what if practices decide not to use a technical coordinator? Has the risk and loss of benefit been assessed? And then Shastri was also saying that she thought she would struggle with the tech. So I thought you might want to cover both of those together, really.
Yeah, so I mean, obviously we can't force people to follow the best practice that we're going to give them, but people fairly quickly, once they experience the training and running their first group clinics, realize the importance of having a technical facilitator. I think in terms of the difference between group clinics in the real world and group clinics in the virtual world is that the person who's going to be the technical facilitator does need to feel, at least open to learning how to use this technology in the same way that Helen has today. It's not complicated, it's quite simple. It's just a question of being able to get people to, use their video, use their microphone, etc., watch the chat. You probably need, as well as the technical knowledge of the system that you're working with, you also need to be somebody who can be quite quick on their feet and process information and watch what's going on. I also think we ought to be very clear that what we've experienced today, we've got, I think at the last count, it was something like 25 people on this training. This session today, and if you imagine this with a group of 6 to 8 patients, it would be much less complex to manage from a facilitation point of view. So I think that in terms of the skills, people fairly quickly get on up and running with it, and often say they find it's much easier than they expected. And in terms of getting people to decide, people deciding not to use a facilitator, they get very strong guidance on that from us. We can't control what people do, but the bottom line of it is that it would take the clinician twice as long to deliver the session, and that's probably going to be the biggest incentive, because they could actually delegate half of the session to somebody who's maybe not as senior as them, and let's be honest, as expensive.
Okay, thanks, Georgina. Maggie has also said, and I'm assuming this is about confidentiality, is this not a risk in any group, digital or not digital?
Yeah, I think I can truthfully say that's exactly the case. During any consultation, I think we know that, especially on a one-to-one basis or during a group, there can be risks to a confidentiality breach, and especially, for example, a data breach as well. So I think that's absolutely right. It's how it's particularly managed on a digital format is the most important area, and I think it just needs that little bit of extra, which we provide during the training and through the resources, to make sure that people are aware, just to take it up a notch, to make sure that people are aware that it's just slightly different when we move to the digital world.
Okay, Jason, I'm going to keep you there. There's another question about when training is starting, please.
Yeah, that's right. I mean, at the moment, the key thing that we wanted to do during the pause was actually address some of these risks, and we need to make sure that those are safe and ratified by the people who are working to indemnify this process. So that's exactly what we're doing now, and trying to do that as soon as we possibly can. And so, in terms of a timeline, we really do hope that we'll be able to start the Sentinels themselves assisting us in testing out some of these resources as soon as possible, and then into the early summer period, making sure that we're moving towards a training program for all. So I think the most important thing for us now is to make sure that we focus on the resources that we're producing, and some of the people who have been with us today from some of the arm's length bodies, etc. I'm hoping that they will continue to work with us now on this really innovative way forward for primary care, and make sure that we can get to an agreement in how that stands, and make sure that we can deliver in a safe fashion.
Thanks, Jason. Georgina, can I call you back, please? So Shastri says that she's got 900 type 2 diabetics, with most of them with poor English and elderly and no IT facilities. How can this be addressed?
So, I mean, this is the sort of thing that we can definitely work with you to bottom out individually as part of the sort of being part of a training program. I think there's a number of you on from your practice here, so this isn't a training session today, just to be absolutely clear. But there's a couple of things for you to think about in terms of how you use video group clinics. The first one is, if you have people who speak a foreign language, which speak English as a second language, you, through a video group clinic, you have a really unique opportunity to actually run consultations and reviews for that group of people in their own language. If within your practice or within your PCN, or even broader than that, you have clinicians who speak that person's native language and members of staff who speak that person's native language who could act as facilitators, you could actually run the whole thing in the language of the native speakers. Alternatively, the only person who might need a translator would be the clinician. So there's some really interesting things that we can do, because we are not bound by geography with a video group clinic model. In terms of accessing technology, I think that's something that you do need to look at and understand really well about your population. So you can, I think the ownership of smartphones in the UK is now sitting at about 89%, if I'm correct on that. Anna, you might be able to just pop in the chat and let us know. And so remember that people don't need to have a computer, they could use a smartphone. If that's not the case, they can also work alongside a member of their family as we come out of restrictions around lockdown, with their family members sitting alongside them and working with them on the technology side. So there is some really good opportunities to actually overcome some of these barriers. There's so many ways that video group clinics actually make care more accessible, and following on from COVID, people are much more tech savvy than they've ever been, including people who perhaps before wouldn't even have thought about putting their foot in the water of using technology, because there's a very strong incentive, if it's the only way that you can see your family, for people to stay connected via video. So I think we need to really watch and understand what's happening with our population, because I think our old preconceived ideas about people's ability to use technology may be very different now as a result of COVID.
Okay, thanks, Georgina. So there's no more questions in the chat column. So unless anything appears in the next couple of seconds, I'm going to hand back to you to close the session, Georgina.
Okay, does anyone want to come off mute, or do we want to have a 5-minute quick discussion before we, is there anyone who's got not so much a question but like a comment that they'd like to make? If you want to unmute, and we've got a couple of minutes to.
Hi. Hello, hi Georgina, hi Jason,
Hi.
hi colleagues. It's Paul here, the head of Perceptions in General Practice Nursing. So for me, as the person who's been involved with commissioning this piece of work, and I know we've had some sticking points in just trying to get it moving forward, can I just say, it is such a fantastic piece of work, and the work that you guys have put into it has been incredible, and it's been great, Helene, for me to hear from a patient's viewpoint, a person who is having support in terms of video group consultation, just how effective it is. So I think it's kind of re-inspired me to kind of really keep pushing through some of the kind of technical problems that we've had. It's really important we get the medical defence organisations to understand what this is about, how we manage the risk safely. And I think today's session has really helped to kind of galvanize just how you can do it well, and the overall benefits that it has to people. So thank you to all the Sentinels and to you and the teams that have been involved, Jason and colleagues, who have really pushed this forward to make it successful. And at a national level, I will keep doing my best to keep getting it through the system so that we can get the green light to push ahead at pace. So thank you so much.
That's brilliant, Paul. Anyone else from our guests today who would like to comment or reflect on what you've heard, or any clinicians who, Rupa or Ellen or anyone? Rupa.
Oh, hi. So I just thought I'd go through what we do at our practice at the moment. So to address the consent and confidentiality, and thank you again to Helen for explaining it from a patient's point of view. So from the outset, in the very first email, we send lots and lots of information on consent and confidentiality. We then send a second email with the Microsoft Teams link in for the session. And again, there's a whole list of consent and confidentiality on there, and also a confidentiality form, which we have used our face-to-face form, but actually added extra bits onto there to be more in line with the virtual world. When we start our video group consultation, we have a slide up which also outlines the confidentiality and consent concerns. And then the facilitator or myself will go through all the rules. So treating it like a consulting room. So this is your virtual consulting room. Keep the door shut. It's only us allowed in this room. This is a safe space. Whatever goes on in this room stays in this room. So I paint that kind of picture for our patients. And then we talk about, no mentioning of third parties. We're not going to have other people in this room walking past in the background listening in. There won't be, the sessions are not recorded, and we don't expect any patients or anybody to then record the sessions or take any photographs of the session. And we just make sure that everybody is happy in that space. And we've already had the confidentiality and consent form emailed back by the patients, but we also get them to write I consent. And as Helen mentioned, if anyone does enter late, we try not to have them, because it does disrupt the flow. But obviously in our postnatal group, people did come late because they're busy with their babies, and I think we've got to be mindful of that and inclusive of that. So we did go through any confidentiality concerns again with anyone that entered the consultation late. So I feel that we do try our best, and as one of our patients also said, well, this could happen in a face-to-face group consultation. And it's true, it could happen, but it doesn't, because patients respect each other, and they respect that they're all in the same boat, and they wouldn't do that to each other as we wouldn't do that to them. So I hope that explains how we've mitigated the risks, and anything that Jason's also working on at the moment, we will of course encompass that into the package as we see it.
Thank you so much. Anyone else? Just one last comment or reflection before we move towards the end of the session. Anyone else like to contribute? Hi, Ellen.
Hi. I don't know if it's worth just pointing out some of the work that the British Society of Lifestyle Medicine has been doing in getting the sort of global feel for this, that can reassure us all that we're not doing something weird and wacky over here in the UK, and that there's a massive global movement to do virtual group consultations. There have been a couple of seminars that have had I think hundreds of people from across the globe. So something like, let me just see here, 718 people registered to look at the webinar across 50 countries, and 347 of these registrants were already delivering face-to-face group consultations, and they had already delivered virtual group consultations in 116 of these clinicians across the world. So, and there's there are two published bits of evidence to show that they're as effective as face-to-face group consultations and very well accepted. And there's huge amount of evidence coming out of the Cleveland Clinic in the US, and also the University of California, where they've had, I think, again, thousands of patients, greater than 160,000 in the Cleveland Clinic, and they've converted over 30% of those to virtual groups. And America, as we can all appreciate, has a lot more litigation and a lot more regulatory frustrations than perhaps we have. So I think it's very reassuring.
Thanks, that's really helpful, Ellen. We'll maybe capture some of those statistics and we'll send them round afterwards, perhaps, to the group, if everybody would find that useful. So we're coming to the end of the session now. It would be really helpful for us to understand from those of you who are here today what you think you might do as a result of attending today. We're looking to what your next step would be. So if you're from part of an organization, it would be useful for us to know what you're going to if you're going to go back and talk to people, what the sort of next step would be for you. We'd also like you to give us two bits of feedback before you leave. One, to tell us something that worked really well about today's session, and something that we could do to make a symposium like this even better next time. So if you could write in the chat one chat which covers what you are hoping to do as a result of having been here today, and then a WW label for something that worked well, and an improve label for something that we could learn from, it would be really helpful for us, because every time we do these kind of pieces of work, we want to continuously improve and live that way. So once you've done that, then you please do feel free to sign off. We will be following up with you all. If you haven't already posted your email address, then we may not have it, so please do, so that we can follow up with you, and we will be in touch to see how we can work with you to move this video group clinic program forward. Thank you very much on behalf of the delivery team. And Jason, I don't know if you want to just add a few words to that yourself.
I do. Great. Thank you very much to all who have attended today. We're really looking forward to working with you as we move forward with this on a national basis. And we really, as Paul mentioned there, are really keen to make sure this makes a difference for both the long term of primary care and all our patients that are within there. So thanks very much. Have a great weekend and a free bank holiday now as well. And we hope to speak to you all soon. Thank you very much for your help.